I'm Kathy Powderly. I'm the director of the John Conley Division of Medical Ethics and Humanities here at Downstate, and had the privilege yesterday to meet Mr. Alfred Lax Carter, Jr., and in an open forum that was mostly students, which was awesome. And so he has been invited to be the keynote speaker for this Cancer Disparities conference, and brings the life experience of being the grandson of Henrietta Lacks. And so I'm not going to say there is a description in the program of his background, but I'm going to let him start by telling you whatever parts of his story he would like to share with you. And then will have some mics so that we can take questions and hear from you what you would like to hear from Mr. Carter. And I'd like to start by thanking him and his wife Jewel for coming to Brooklyn, coming to Downstate, sharing their life and their experience with us, especially with our students, and I look forward to hearing even more about his story today.
Thank you. Good afternoon, everyone. I'd just like to say thank you for coming and participating in such a profound event, talking about disparities in cancer. As Ms. Powdery said, my name is Alfred Lax Carter. I'm the grandson of Henrietta Lacks. My mother was Deborah Lacks. Growing up, there wasn't like a lot of talk about Henrietta, mainly because my granddad and his sons really didn't, they really didn't take how Henrietta was treated. In 1951, she passed away from cervical cancer. She went to Johns Hopkins Hospital for treatment, and back then the treatment was so barbaric, they were actually sewing radium onto her cervix, which was burning her from the inside out. My oldest uncle, Lawrence Lacks Sr., he was the only one who really had recollection of who his mother was, because my mom and my other two uncles and my Aunt Elsie were so young when Henrietta passed away. My mother was just 2 years old, so she never knew her mother. All these events transpired back then, and my granddad and my oldest uncle, they tried to block everything out. There was a trust issue between the family and Johns Hopkins. For years, my granddad and my uncles, they never knew that the HeLa cell existed. It was found out by mistake. A family member who lived down the street from my uncle and my aunt Barbara, the family member had a friend who worked at the NIH in Bethesda, Maryland, and she introduced my aunt to this guy, and she introduced her as Babette Lacks. And he was like, "Lacks, are you related to Henrietta Lacks?" And she was like, "Yes, that's my mother-in-law." And he went on to tell her about all these wonderful and amazing things that they were doing with her cells. And all this was unbeknownst to the family. So she went back and told my uncle, and he told my grandfather, and so they started to make calls, and they were still kept in the dark. They were told, like a lot of times they were putting, like HELA stood for Henrietta Lacks. They were saying that it stood for Helen Lane and Helen Larson, trying to cover up the fact that this was an African-American woman from Baltimore. So Rolling Stones did a very in-depth article on the HeLa cell and who Henrietta Lacks and her family was. And that was really my first time really knowing who Henrietta was and what contributions she made to not only, the United States, but the world. As we know, Henrietta Lacks was used to go up in space to test zero gravity. They used it to create the vaccine, the polio, stem cell research, in vitro fertilization. I mean, you name it, the HeLa cells have contributed. So as we move forward, the author of the book, The Immortal Life of Henrietta Lacks, Rebecca Skloot, she reached out to the family, and my uncles and my granddad, they wanted no parts of it. I mean, because they thought like, here's somebody else trying to come and take advantage of the family. So my mother, being the trendsetter that she is, she gave Rebecca a chance because my mother wanted to know who her mother was. She wanted to know the things that she liked. Did she like to dance? What kind of person she was? So her and Rebecca developed a rapport, and they started going around to different family members down in Clover, Virginia, which is in Halifax County, conducting little personal interviews to find out who Henrietta was. So the book took 10 years to write. And there were a lot of things that my mom didn't know about her mother that she finally found out. Also, a lot of things that she found out about her sister Elsie, who passed away at age 15 in Crownsville State Hospital. That was a very disappointing and heart-wrenching part of the book to me. So as the book was almost completed, my mom was already suffering from heart disease, and she passed away like 9 months before the book was released. So Rebecca, she went on and published the book, and the Immortal Life of Henrietta Lacks has been instrumental part of getting the information to people about Henrietta. As we all know, it's a required reading for a lot of universities and high schools. I mean, I be on a plane sometimes and I see people reading the book, and I might walk up to them. I'll be like, "It's a nice book, right? Very informational." And they be like, "Yes, you ought to read it." And I'll be like, "I've read it quite a few times." You're right. "How you doing? I'm Henrietta's grandson." And they be like, "Really? Can I have a picture?" Okay, wait till the plane lands and we can take a picture. But a lot of people ask, well, how does your family feel about what Johns Hopkins done to your grandmother and to your family? I think it's like how you perceive what's right and what's wrong. I think wrong was done, but not intentionally, because of the time, 1951. Race played a major part. In Baltimore, we all know that Johns Hopkins was one of the only places that African Americans could go and get treatment. So, I mean, I really feel like out of the bad that was done, you can't be upset, you can't be vexed or anything like that, because of all the good that have came out of the HeLa cell. It just warms my heart when people come up to me and tell me that your grandmother saved my life. I had cancer because of your grandmother. I have children because of in vitro fertilization, stem cell research, everything. So when I see the HeLa cell that came from my grandmother, Henrietta, saving lives and contributing to so many great advancements in the medical world, it makes me happy. It makes me proud. So my mom, when she passed away, I vowed that I would continue to push forward and to get out about the legacy of Henrietta Lacks, to keep it alive. And I shared last night that I'm in the process of getting her on a postage stamp. We have a street named after her in Baltimore. We have a highway dedicated to her in Baltimore. There is a building that Johns Hopkins is constructing as we speak, and it's going to be named after her. I know that there's not, monetary, money given. A lot of people ask that question, well, have you been compensated? No, we haven't. And like I shared last night, if Henrietta was not an African American woman, I think the family would have been compensated. And it wouldn't have taken this long. But Henrietta left a platform for her family to be able to take advantage of. So I'm here to talk about disparities and, poor neighborhoods and things like that, where people, they tend to not want to participate in clinical trials. I'm getting ready to partner with the ACR and go around and speak to people and let them know, hey, look, it's very important that we participate in clinical trials, because we need people to participate, because the medications that they're creating, it has to be for us. Because if they're creating medications for people not of color, then a lot of times it don't work on us. It doesn't work. So, we need to let people know that the mistrust and the disconnect between, communities and academia, it happened to me, it happened to my family, but it might not help you, but it will help people behind you that's coming in the future. So Henrietta saved lives, and that's what I'm doing, so to speak, also. As I said, I live in Baltimore, Maryland. I have a transitional housing program, and I help transition men that's coming home from incarceration. I felt like it was a mission that I needed to dedicate myself to, because I've been there and I've done that. And I know that there's men coming from prison that doesn't have family support to be able to transition back into society. I shared last night that a guy just came into my house 3 weeks ago. He was locked up for bank robbery. He was locked up 30 years. And when he got out and he was in a federal halfway house for 5 months. And they just kicked him out. No resources, no support, anything. He tried to get jobs. He tried to reach out to family members, nothing. So what did he do? He went into another bank and he robbed the bank, and he didn't take the money. He left out and he went across the street and sat on the curb and waited till the cops came and arrested him. So he was locked up for another 2.5 years. And then his caseworker contacted me and said, Tony Wright needs help. And I think your program will be great for him. And I went and I spoke, and the judge released Tony, released him into my program. He's in my program right now. We're in the process of getting all his documents and his ID so he can get a job. I took him to the supermarket so he can buy food, and it was just overwhelming for him, like to be in a place with so many people and so many things going on. So that's what I'm doing, to give back to society, to help lives and to help men, to be able to come home from prison and to take care of themselves and their families and not be a danger to society. So I'm here. I'd like to thank Dr. Powdery because, she's been very instrumental in getting me here. Her and Jenny and Dr. Laura Botello, thank all of you for bringing me here.
Well, we don't have too many standing ovations around here, so just so you know. That's awesome.
Thank you.
As I told Mr. Carter last night and yesterday afternoon, I had heard his cousins as well speak at a research ethics meeting a few years ago, and I told them as well, I think their grandmother would be very proud of them and what they've done with this story. I mean, clearly, the state of medicine and informed consent in 1951 was very different than it is now, but we did have some consent for treatment, probably much less for research and none for tissue cultures, But one of the things as I looked back at the book to get ready for this visit, there was a quote from Alfred's mother, Deborah, who, when she found out about all the wonderful things that had happened in medicine because of Henrietta's cells, she said, well, she did all these things for medicine, why can't her family afford to go to a doctor? And I think that's really the crux of the issue in terms of disparities. So for the most part, I think you don't want to hear from me. I think you want to hear from him, and we want to hear from you what you would like to hear from Mr. Carter. So we have some student volunteers. I don't know how much informed consent went into that voluntariness, but the students are running around with some microphones if you all would like to ask Mr. Carter some questions. Yeah. Oh, you got... if you can, just identify yourself and say kind of what... just like who you are and what you do here, so we know.
I'm Dr. Tandega Mazibuko. I specialize in radiation oncology. Cervical cancer, thank you for a wonderful speech.
Can you hold the microphone closer?
It's very...
That's better, thank you.
I am Dr. Tandega Mazibuko. I specialize in radiation oncology. I'm from South Africa, Durban. Cervical cancer is very close to my heart because it happens mostly amongst the women of color. But I just want to share with you, sir, regarding the treatment of cervical cancer brachytherapy, which goes straight into the cervix. The treatment is very diverse, and some centers will thumbsuck some of the treatment in other areas. We still really need advocacy on that area, like in the center where I was. Some patients were treated exactly as your great-grandmother, and I think we really need your support in advocating for cervical cancer patients. I know that you are doing great on prison reform, but we really need someone to advocate on cervical cancer to unify the treatment, because in my center, patients were treated exactly like your grandmother, and I was vocal, highly vocal, on eradicating that treatment, which was changed in 2013. From 2016, patients were treated with the wrong dose, which was 7-gray stat, which is just like pouring water on a patient's. I just wanted to make you aware. I know radiation oncology is not part of this program, I'm requesting maybe if possible that because colorectal cancer, although you don't treat with radiotherapy right in the first stages or in the primary stage of treatment, where they use more chemotherapy, but palliative, we use radiation. So I would really appreciate if we can incorporate radiation oncology and invite some radiation oncologists, because there's really a lot of things that are ongoing that you may not be aware of.
Thank you.
Do we have other, yes?
I have a question.
Okay.
My name is Antonio Baines. I'm a pancreatic cancer researcher. Again, thanks for coming. Really, this story is a really touching story. So I have a question. Do you and the family still have a relationship with the author of the book that came out, and how is that relationship, or are there any funding that's going to the family? I'm just curious from that, because again, some people have commented on
Right.
that relationship.
Right. No, ma'am. Like, okay, to answer your question, yes, we still have a relationship with Rebecca. It's been a lot of speculation on the subject of when her and my mother was writing this book, that they had some sort of contract or some kind of agreement. So when my mother passed away, like, no one knew because my mother didn't discuss it. And if she did have a contract with Rebecca, with my mother being gone, Rebecca is not going to come out and say, well, I owe this family X amount of dollars. So what she done was she constructed a foundation, and proceeds, a certain percentage of the proceeds from the book go to this foundation, and it's only used for if you want to go to school, for medical treatment, like emergency things, but it's only a $10,000 cap.
That's an important piece of information.
Right. So she's in China right now, so I mean.
But that's why we have you here, not her.
Right. So yeah, I mean, I would love to know if she really had a contract with my mother or not. But to me, she isn't being fair with the family. But I can't hate on her because she wrote the book. She's reaping the benefits from the book. That's why I said it's up to us as family members to find our own lane.
So I have a story that I didn't tell you about that, actually. When the book first came out, Rebecca was doing the rounds of bioethics programs, and I actually tried to invite her here. And it was shortly after the summer after the book came out. And she had an agent already, Kenny. Kenny went to SUNY Albany. I still remember many conversations with Kenny. But her honorarium at that point was $15,000. In the week it took me, although I had that money thanks to the Conley Foundation, which funds my division, I wasn't comfortable paying that to one person. I pay a respectable honorarium. I thought it was outrageous. So I said, I need to talk to somebody higher than me, even though I have the final say on the use of my funding. In the week it took me to do that, it went up to $20,000. And I said no. And then I heard some members of your family speak, and I said, I don't want her, I want you. When I said that's why you're here not because she's in China and we couldn't get her. You're here because we wanted to hear your story.
Thank you.
And right. Well, it is ethics, exactly. And as I said to the students yesterday, don't worry, we are paying Mr. Carter an honorarium. So, it is. But I think it's really important. As I said yesterday when we were chatting about this. The people at Hopkins who set out to do this were not bad people setting out to do bad things. And they were very excited when they found these cells that didn't die in their petri dishes like all the other cells did. But there was something that, you know, it's slippery slope, and it's a really important case study for us to learn from. And maybe you could share with this audience the story that you shared in response to Dr. Roman's question yesterday about what happens now when people want to use HeLa cells.
Okay, well, there was a scientist who he posted the genome online, and the family was contacted by the NIH. So they called a family meeting, and we went and met with Dr. Collins, who was over the NIH in Bethesda, and we came up with a solution that we came up with a board of family members to sit on the board at the NIH to be able to control who uses the HeLa cell. Whoever wants to use the HeLa cell now they have to fill out a form and reveal what they want to use the HeLa cell for, like what scientists are going to do with it. So we basically have a small say now in what the HeLa cells are used for.
As opposed to when these cells started to be used for things, they are still in every research lab in the country, or maybe in the world. And except nobody really thought about what does HeLa stand for, that these cells came from a human being who had a husband and 5 children. I think that's just really important to step back and reflect about that, how we, use things, and there are things in our lives as healthcare providers. And I think the other message that you touched on, which is really important, is trust. Trust between. There's a good reason for African American people and other vulnerable populations, people of color, poor people, many of the people we take care of in this medical center, to not trust us, because there were bad things that were done to them. So we have to the Tuskegee study as well, exactly. So I think we need to, the person who wrote the book Bad Blood about the Tuskegee syphilis study is a very close friend of mine. And he still gets phone calls from researchers saying, what is this Tuskegee thing, and why won't people participate in my studies? The answer is that there's a lot of myth as well but it's based on the fact that bad things happened, and we need to be cognizant of that. I'm the very squeaky wheel in our IRB, the Institutional Review Board. We talked about that yesterday, what those initials stand for, about how even though a study might seem relatively benign, we can't just decide that the community is going to participate. We need to talk to them about it. And of course, the Arthur Ashe Institute here does a lot of work in that regard, along with the Disparities Center. So, other questions? Dr. Salafu. Dr. Salafu says we have 5 more minutes. Somebody who's got do you have the microphone? Go ahead. Go ahead.
Hi, my name is Janine Bada. I'm a graduate of the School of Public Health here, and I work for the cancer support community as a clinical trials educator. I also worked for 8 years for Emerging Med, a clinical trial matching service. And I just want to add to what you're saying about the barriers of vulnerable populations not participating in trials. I can't tell you how many hundreds or maybe thousands of times I've spoken with patients on the phone who can't get into a trial because they don't have the right health insurance. That shouldn't be happening. They can go to trials at NIH and NCI, and there are some pediatric trials that children can get into, but for the rest of the United States, it depends on what kind of insurance you have. Not at every institution, but at a lot of them.
It shouldn't be.
I agree.
The health insurance should take care of your treatment. The research is separate. On the other hand, one of the dangers is that the incentive, if you don't have health insurance, if you can get into a trial, where they will take, and people will argue that as a research subject, you're often taken better care of. You get more transportation, you get more personal attention. So that's an undue incentive, perhaps, to participate in research and not realize that it's not treatment.
And real quick before we end, the reason why I do the transitional housing program is because when we were shooting the movie, The Immortal Life of Henrietta Lacks, Oprah played my mother in the movie, And
He took Oprah to dinner and paid for her.
I sure did. And what, you know, the time that I spent with Oprah at dinner, it was very enlightening. It was very real. And we talked about me doing this transitional house. I told her, because I had a small part in the movie also. I was the turn the station man that told the nurse, I'm here to give blood in case she needs it. So I did have a speaking part. And I got my SAG paper, my SAG award, my SAG papers a couple weeks later. Thank you. And I told Oprah, I said, well, so many people told me I did a great job. I think I want to try my hand at acting. She was like, no. She said, your mission is to help people, help these men coming home from incarceration. She said, this is a God moment, Alfred. She said, look where you've been. Because I was in prison for 15 years, from 2001 to 2016. When I was released in 2016, within 7 months, they were shooting this movie, and they wanted me to be a part of it. And I'm sitting down at dinner with her, and she said, look where you've been, and look where you are now. She said, this is your grandmother and your mother's spirit dwelling through you. She said, I can feel it. She said, so what I want you to do, I want you to get this house, and I want you to help men coming home from incarceration. She connected me with this guy who has a book called Righting My Wrongs. I think his name's Shaka Senghor. And him and I talked, and so thus, this is why I have the transitional house. She said, if this is what you really want to do, I'll help you. So she gave me a grant for $100,000 last year. And then she gave me another grant of $100,000 this year. The house that I have right now is not in real good shape. Like it needs some repairs. So what I'm leasing the house. So right now I'm trying to buy a house to house more men, because right now I can only house up to 6 men in the house that I have. I want to buy a building that's going to house at least 100 men. And I want this house to be a place where they can come and receive training, like trades, electrician, plumbing, HVAC, things that men, when they come out and they receive this training, they'll be able to take care of themselves and their family without struggling. And this is my vision. This is my mission. I have a board set up outside, so when you all come out, visit my board, you know, I'm asking everybody to help with the my mission to get this house. What I'm doing is it's like a limited edition. It's like 2,000. It's only going to be 2,000 posters of Henrietta with her actual signature on it. I'm the only one who has her signature, and it's only going to be 2,000. You all will be the first people. You all the first people to know about this. I'm going to the ACR in Atlanta the end of this month, and I'm just ready to take this to another level. I was telling a young lady last night that this is not just going to be something in Baltimore. This is going to be something in every major city, in every community where there's men coming home from incarceration and needs help.
Like I said, your grandmother would be very proud of you.
Thank you.
Unfortunately, I think we have to end because I think we need to move the program along. But I again would like to very much thank Alfred for coming and sharing his story with us. And I hope that this is the beginning of a long relationship between Downstate and you and your family.
Thank you.
Okay, we're going to go ahead and get started. Great session. Definitely great words that were spoken that we all need to keep in mind as scientists and researchers. So we're going to change the topic to pancreatic cancer. Pancreatic cancer. My name is Antonio Baines. I'll be one of the speakers after the speaker that's about to come forward. I'm going to give a little small introduction. So our speaker next, his name is Dr. Douglas Fearon. He's an MD. He received his MD from Johns Hopkins Medical School and has been a professor of medicine at Harvard Medical School, Johns Hopkins, and the University of Cambridge, where he was also the Sheila Jones Smith Professor of Immunology. He currently is the Walter B. Winston Professor of Pancreatic Cancer Research at Weill Cornell Medicine and Professor at Cold Spring Harbor Laboratories. He has done research in various areas, including complement systems, memory, CD8, T-cell development, and most recently, tumor immunology. Let's give a hand to Dr. Fearon.
Thank you for inviting me here to participate in your symposium. It's difficult to follow with the cold science a compassionate, sensitive discussion of a past medical injustice. And as I was sitting listening to this, and I had some association since I went to Johns Hopkins Medical School and did my internship and residency there, I was reminded of an experience that I had as an undergraduate in college. And we had Martin Luther King to speak at our chapel. And I felt that I had many privileges in life and had some sense of guilt about that. And I always remember his discussion of saying, well, convert that guilt into a responsibility to make the most of your advantages. And none of us can ever do that, but Mr. Carter certainly has contributed more than most of us. I'm going to be talking about a chemokine receptor called CXCR4. And I'm going to present to you not the preclinical work that led to us focusing on this, but I'm going to present the results of a phase 1 clinical trial. The preclinical work in mice is interesting, and it led to the rationale to doing the experiment in humans, but it is the experiment in humans that all of us are interested in. So I'll focus on that. I disclose that I'm a co-founder of a LLC based on a patent that University of Cambridge filed based on our work, and I'm on the SAB of a biotech company called Itios. I will not talk about, I'll obviously talk about the clinical application of our discovery in mice and pancreatic cancer in Cambridge, but I don't think I'm going to benefit financially from this work, but that's not why we go into research. Okay, the 5-year survival of pancreatic cancer is between 5 and 7%. It's not shown any improvement despite other cancers showing marked improvement in survival. African Americans have a 25% increased incidence in pancreatic cancer. Perhaps it's related to what the previous speakers had talked about. Obesity does predispose to pancreatic cancer. But regardless of your race, this is not a good disease to have. So, how is immunotherapy faring in pancreatic cancer? You've probably heard that immunotherapy is being proven of great benefit to a subset of patients with a subset of cancers, melanoma, non-small cell lung cancer, smokers, some patients with renal cell carcinoma. But pancreatic cancer, in a trial published in 2012 of anti-PD-L1, the PD-1 checkpoint, no pancreatic cancer patients responded, and none have in any trial subsequently. So pancreatic cancer has been resisting immunotherapy. Is it a cancer that we will not be able to modify the course of with immunotherapy, or have we simply not been doing it the right way? Have we not discovered the immune suppressive pathways that operate in pancreatic cancer as compared to, say, melanoma? So that was a question that we started out to pursue back in about 2012, around the time of this publication. We had discovered an immune suppressive pathway 2 years earlier, and we decided to say, is it operating in pancreatic cancer? Now, this is a PD-1 checkpoint. I just put it up briefly to say why I think it's not working in pancreatic cancer. The tumor cell expresses an antigen that T cells can recognize because T cells, clones of T cells, will have T cell receptors that recognize that peptide located in the groove of the MHC class I membrane protein on a cancer cell. The cancer cells and other normal epithelial cells protect themselves from immune attack by upregulating a membrane protein called PD-L1. And PD-L1 can engage a receptor on the T cell called PD-1. And when PD-1 is engaged, it turns off T cell receptor signaling. So a therapy designed to inhibit this suppressive pathway is either antibodies directed to PD-L1 or PD-1 preventing that interaction. But you can see that this PD-1, PD-L1 inhibition will only work if T cells are encountering cancer cells. If the T cells can't even get into the cancer, then antibodies to PD-1, PD-L1 will be ineffective. So do T cells get in the cancer cell nest of pancreatic cancer? They do not. These are tissue microarrays of biopsies of pancreatic cancer, and the cancer cells are in red, and the T cells are in this white greenish color. And you can see the T cells are actually in between the cancer cell nests. They're in the cancer stroma. They're not coming in contact with the cancer cells. So 5 of the 6 biopsies show that phenomenon. This biopsy shows that T cells can get in to cancer cell nests, but this patient has microsatellite instability, MSH high, it's very immunogenic, and having a lot of antigens that the immune system can recognize overcomes this block for T cells getting into the cancer. But we cannot make these cancers more immunogenic. So we have to discover whether or not there is a process that excludes T cells. There's a paper published 2000 from investigators at the Massachusetts General Hospital. Active movement of T cells away from a chemokine. The chemokine at that time was named SDF1, it is CXL12. And you can anticipate that CXL12 is the ligand for CXCR4. There was selective repulsion of subpopulations of T cells at high concentrations of recombinant SDF1 or CXL12. So in the chemokine, instead of attracting T cells, which express CXCR4, actually repel them. Well, given that, isn't it interesting that the pancreatic cancer cells are coated with this chemokine, CXL12? This is a mouse model of pancreatic cancer. It's a so-called KPC model that Dave Tuvison developed. And the stains are with anti-CXL12 in red, anti-cytokeratin 19 identified in the cancer cells. This is a merge. This is just showing the CXL12 staining and the CXL12 monoclonal antibody staining in cancer cells. We can see the same thing in human pancreatic cancer. These are serial sections of human pancreatic cancer. Here the green stain is anti-CXL12. The cancer cells are staining green. The T cells in red are excluded from the cancer cell nest. And here is this cytokeratin 19 antibody simply identifying that these are the cancer cells. This phenomenon is not restricted to pancreatic cancer. It occurs in a mouse model of non-small cell lung cancer. The cancer cells are coated with the green anti-CXL12 antibody. The red CXL12 antibody, CK19, is in green. And human pancreatic cancer is stained with monoclonal anti-CXL12. Human ovarian cancer, prostate cancer, colorectal cancer, and we've even found examples where normal epithelial cells take up CXL12. So we have a situation where we don't even we did not know the mechanism by which cancer cells capture CXL12. They're not making it. Fibroblastic cells in the stroma are making this chemokine, and we've recently discovered how the cancer cells take it up, but we didn't need to know that mechanism to wonder whether or not this is important and accounts for why T cells are excluded from the cancer cell nest, why pancreatic cancer escapes from immune control. So what I'm trying to say that we envision happening is cancer cells have an ability to capture CXL12 in blue. Then the T cell and other immune cells come in. There's a receptor for CXL12, CXCR4, signals the cell, and it migrates away. So there was a small molecule developed to inhibit CXCR4 back when there was not yet efficacious treatment for HIV. CXCR4, the receptor for CXL12, is a co-receptor for HIV. And one of the drugs developed to block HIV binding to CXCR4 is this molecule called AMD 3100. It interacts between the extracellular domains of the receptor and blocks not only HIV binding, but it was discovered to block CXL12 binding. It's clinically approved to release hematopoietic stem cell from the bone marrow. In our preclinical studies, we gave this molecule continuously by osmotic pump to mice with pancreatic cancer, KPC mice, and the immune system stopped the growth of the tumor, and the tumor became sensitive to a neutralizing antibody to PD-L1. That was in mouse system. On the basis of those findings, we submitted an application in 2014 to Stand Up to Cancer and the Lustgarten Foundation to do a clinical trial. The clinical trial, we were only allowed by the company providing AMD 3100 for the trial to give it for 7 days. And this is obviously too short a period of therapy for immunotherapy. No other immunotherapy works in 7 days, clinically works. But we were hoping that we could obtain evidence that blocking CXCR4 in pancreatic cancer and colorectal cancer patients would heighten the immune reaction in biopsies of metastases. So we took core biopsies before the started infusion of AMD 3100 and at the end of 7 days, and then compared the biopsies, the paired biopsies, by analyzing the transcriptome. The expression of genes or expression of immune genes, are they influenced by giving AMD 3100? So this is an update that was provided to me by Daniele Biasi, a computational biologist in Cambridge. The trial was done in Cambridge, UK. And when we simply subjected the paired post versus pretreatment biopsies to pathway analysis, the top pathway that was enhanced was an immune pathway of allograft rejection. So we not only enhanced the immune reaction, AMD 3100 not only enhanced the immune reaction in the tumor biopsies, but it was precisely the immune reaction that one would like, because allograft rejection, as you know, if you can treat cancer as an allograft, then the immune system will kill cancer. The other immune pathways are upregulated: inflammatory response, interferon gamma response, IL-2, STAT5 signaling, and a type 1 interferon response. That was colorectal cancer patients, and they had the same results in pancreatic cancer patients. So remember, I described to you, I only showed you coding of pancreatic cancer cells with CXCL12, but I told you colorectal cancer cells are also coded with CXCL12, and indeed treating either cancer by blocking CXCR4 improves the immune reaction in the tumor biopsies, precisely the immune reaction that an immunologist would be looking for. Now, we were limited to 1 week of therapy, and this was not enough to have a real clinical outcome. But what about, can we compare the changes in gene expression in the biopsies of patients treated with AMD 3100 to the changes in gene expression induced by anti-PD-1 in melanoma patients, which does respond to anti-PD-1? Do we induce the same changes? And these are the pathways that are immune pathways induced in melanoma patients in their biopsies by treatment with anti-PD-1 in collaboration with Tim Chan, who published his trial in Cell. So that gives us at least an opportunity to suggest that AMD, if given a longer period of time, would have a clinical effect. What is happening to very specific components of the immune pathways in the cancer biopsies? So T-cell receptor genes are upregulated in colorectal cancer patients and pancreatic cancer patients, and in the trial of a anti-PD-1 in Sloan Kettering in melanoma patients. Granzymes and perforin are the proteins that reside in cytolytic granules of CD8 T cells that enable them to kill normally virally infected cells, but to kill cancer cells. We also found upregulation of granzymes and perforin in the colorectal cancer patients, the pancreatic cancer patients, with false discovery rates that are comparable to the upregulation of the expression of those genes in the melanoma patients treated with anti-PD-1. Can I present additional evidence that might suggest that this enhanced immune response actually has a negative effect on the cancer? So Daniele investigated the expression of genes that would be characteristic of the cancer cells in the biopsy, only expressed by the cancer cells in the biopsies. And looked at the expression of those cancer cell genes in each of the individual colorectal cancer patients and correlated them with the upregulation of granzymes and perforin. So a downregulation of cancer cell gene expression correlates with upregulation of the genes encoding the effectors of CD8 T cell killing. We also found the same relationship in the pancreatic cancer patients. So again, inferential evidence to support the possibility that inhibiting CXCR4 will enable the immune system to kill cancer cells in colorectal and pancreatic cancer. If that is meaningful, another test would be to ask which pathways are inversely correlated with the expression of T cell receptors in AMD 3100 treated colorectal cancer patients. So does upregulation of T cell receptors, which we found in the patient's biopsies, what downregulated pathways does that upregulation correlate with? And for the most part, it's terms related to cell cycle. So we would consider the most likely cells in the biopsies that be cycling would be the cancer cells. Genes, so then Daniel A. did, I thought, an imaginative computational biology approach. There have been studies attempting to determine biomarkers that would identify melanoma patients that respond to anti-PD-1 or anti-CTLA-4 compared to those who will not respond. And so there have been 4 studies where RNA-seq has been done on paired biopsies of melanoma patients, pre-therapy, post-therapy, and then retrospectively comparing the pre-therapy biopsies of the responders versus non-responders. And we find genes upregulated in these 4 different studies: Van Allen, Oslander, Riaz, and Hugo. Those genes that are increased in expression in pre-treatment biopsies that predict response to anti-PD-1 or anti-CTLA-4 are the genes that are significantly upregulated by AMD 3100 in the pancreatic and colorectal cancer patients. That would be consistent with our preclinical mouse studies where we found inhibiting CXCR4 made the mouse pancreatic cancer sensitive now to anti-PD-L1, where without treatment it was not. So I'll close by saying this is obviously an interim report. We're planning a phase 2 trial of combination AMD 3100 plus anti-PD-1 immunotherapy with Liz Jaffe at Johns Hopkins and Brian Walpin at Dana-Farber Cancer Institute. I've just shown you the clinical data of the phase 1 trial done in Cambridge. It was directed by Duncan Jodrell with these people in his lab. I've shown you the analysis of the data by Daniel A. Biasi, to whom I'm extraordinarily grateful. So thank you very much, and I'd be pleased to answer questions.
So hello again. My name is Antonio Baines. I'm going to introduce myself. I'm Dr. Antonio Baines, and no, I'm just playing. You can just read about my bio in your book. So today we're going to talk about pancreatic cancer. I'm going to follow my colleague Dr. Fearon, and so today the focus is going to be on talking about molecular targets in pancreatic cancer. So let's go ahead and get started. Okay. Disclosure, I have a research grant from a company, but that's just to do research, nothing more. So outline for today, give a little introduction about pancreatic cancer just to make sure we're on the same page. and talk about some possible drug targets that I have focused on in the laboratory, and then end up with talking about drug combinations and chemotherapy. So I love audience participation. I'm a professor. I love audience participation. So can someone tell me who this is? Aretha Franklin. Aretha Franklin. And her name, and she's known as the Queen of Soul. Queen of Soul, yes. So unfortunately, we lost her last August. From pancreatic cancer at 76. And unfortunately, we lost many folks. Based on what the American Cancer Society says, about 55,000 folks will come down with the disease in the United States. And of that, almost 80% of them will unfortunately die from the disease. The 5-year survival rate is 9%, so about 9% folks are able to live past 5 years. And pancreatic cancer used to be the 4th most common cause of cancer deaths. Unfortunately, most recently it became the 3rd leading cause of cancer deaths in the U.S., and it's believed in 2030. Now, it's 2019 now, which means 2020 is coming. It's believed in 2030 pancreatic cancer will be the 2nd leading cause of cancer deaths, and nobody knows why. Just to make sure we're all good with what the pancreas does. The pancreas is an organ in your digestive tract. It has 2 main functions. It makes digestive enzymes to help break down foods, as well as it also, so basically digestive juices get secreted into the pancreatic duct, and that gets dumped into the small intestine. So that it makes digestive enzymes, and it also makes various hormones, such as insulin and glucagon, to control blood sugar. So as you can imagine, if the pancreas is compromised in any way, cancer, whatever, pancreatitis, that person is definitely going to have some serious health issues. Now, as you can see, the pancreas is made of many different cells, acinar cells, duct cells, and because it's made up of different cells, that lends it to being able to develop different types of cancers. The cancer that I tend to focus on, and many other researchers focus on in the pancreas, is ductal adenocarcinomas. And the reason why is because basically 90% of all pancreatic cancers are from this origin of adenocarcinomas. And so again, about 90% of most pancreatic cancers are adenocarcinomas, and unfortunately, most of them are diagnosed at late stage. So if you know, look here, late stage, where the cancer's already metastasized. So some major consequences about pancreatic cancer, again, just to make sure, again, forgive me if you know this already, but I just want to make sure we all on the same page. Again, the 5-year survival rate is about 9%. Most patients are diagnosed at late stage, so again, there's really no specific symptoms of pancreatic cancer. People could talk about back pain, jaundice, but really there's no specific symptoms for pancreatic cancer. It's usually found by accident on a CT scan. Most pancreatic cancers are resistant to chemotherapy and radiotherapies, and the survival rate hasn't really significantly, as my colleague mentioned, the survival rate really hasn't changed that much over the past 40 years compared to many of the other cancers. So again, we definitely have a lot more work to be done when it comes to detecting pancreatic cancer early and better treatments. So this is a cancer health disparity conference. I don't want to make the assumption everybody knows what cancer health disparities are, so I wanted to at least put it on the slide for you real quick. And as it relates to cancer health disparity, pancreatic cancer is definitely falls in that category. And why does it fall in that category? Well, this is one of the biggest reasons. The incidence rate is very high, so about 50 to 90% higher the incidence of pancreatic cancer in African Americans compared to other ethnic groups, as well as when it comes to African Americans, they have worse prognosis than any other ethnic group in the U.S. And then also, as it relates to surgeries, usually African Americans don't receive the surgeries compared to other ethnic groups. Now, surgeries is very limited in pancreatic cancer anyway. Only about 10% of all pancreatic cancer patients are even eligible for the surgery. But for African Americans, it's even less. And one of my colleagues came out with a paper, just kind of showing you again this health disparity that exists with African Americans when it comes to pancreatic cancer. So here was a research that was done by colleagues at UNC, where basically they basically use virtual micro dissection and were able to basically categorize different types of pancreatic cancers between basal-like, and classical. And it's similar to what's been seen in breast cancer and bladder cancer. So classical is usually the traditional cancers you see, and then the basal-like is usually much more aggressive. Well, here you're looking at a Kaplan-Meier survival curve, and if you notice, for both the basal-like and the classical is worse in African Americans compared to Caucasians. So again, just showing you that there are differences that are seen when it comes to ethnic groups and pancreatic cancer. And again, we need to do a better job trying to figure this out because hopefully by figuring this out, we'll be able to have an impact on the whole disease population. So I'm a cancer pharmacologist by training, and so I'm interested in trying to basically find novel drug targets, signaling pathways that we can go after to potentially, either cause cancer, either cause cell death or inhibit growth. And so here is just a cartoon showing the pancreas as a time bomb. And you have pliers trying to figure out what wire should we disconnect to deactivate the bomb. Okay, and so that leads me to focusing on now molecular targets in pancreatic cancer. And so, as with many other cancers, there's a combination of oncogenes being activated, tumor suppressor genes being deleted, and it's that combination that leads normal cells to become more and more aberrant and eventually cancerous. And pancreas is no exception to that rule. Here, we're showing different oncogenes and tumor suppressor genes, either activation or inactivation, that leads to these normal cells in the pancreas becoming these different precursor lesions, PANN1s, PANN2s, PANN3s, and it's believed that the PANN3s are the ones that will potentially go on to become actually pancreatic cancer. And so, let me go back real quick. So actually, oops, sorry about that. So basically, yeah. And so one of the oncogenes I want to show you is KRAS. So KRAS is mutated in almost all pancreatic cancers. We're talking about pancreas and colon. Colon is about, KRAS mutations are found in about 50% of colon cancers, but in pancreatic is about 90%. So almost all pancreatic cancers have a KRAS mutation. And just for a quick review, RAS is a GTPase, and so it can turn on and off. And so in a normal situation, RAS can turn on when it gets activated upstream and can signal down the cell, but then eventually that signal stops and it turns off. Whereas in cancer, because of a mutation, RAS stays on constitutively, and that can lead to aberrant cell growth and many other processes that can lead to cancer. Okay. And so, did research, as well as many other researchers have shown the importance of RAS. And so here we took a pancreatic cancer cell line and used shRNA to basically inhibit that mutation, and you see decreased growth, of the cells. And then when you put those cells in mice, you see decreased tumor formation compared to normal cells, showing the importance of RAS even late stage cancer. And RAS can signal down many pathways, as you can see here. There's many different pathways RAS can signal down. Here, because of lack of time, I'm just going to focus on one pathway, this RAL-GEF pathway. RALs are GTPase proteins just like RAS, and we showed that RAL is activated in a variety of pancreatic cancer cells. Okay, we've showed that, and then a colleague of mine was able to show that when you inhibit that particular protein, you can definitely get decreased growth. So you have control here, you have the knockdown of RAL-A, which is represented right here, and then you have RAL-B, where there's no effect, okay? And then when you try to rescue RAL, the tumor comes back again. So showing that RAL-A is necessary for tumor growth. So again, just showing different molecular targets that potentially one may want to go after for targeting pancreatic cancer. But as you may be aware, RAS, again, you would think, well, if RAS is mutated in about 90% of all pancreatic cancer, that's a great target to go after. Well, unfortunately, RAS has been studied for over 30-some years, and we have yet to been able to target RAS successfully. There's no anti-RAS drug in the clinic. although there's a big push by NCI and others to really go after RAS and try to find ways to target it, we still are not successful yet. And so the idea is, well, if we can't target RAS successfully, maybe we can target downstream players of RAS. Who do RAS talk to potentially, as you saw with what I just showed you with the RAL pathway. And so that leads me to a kinase that came up from a microarray screening of cells. So there's this kinase called PIM kinases. PIM stands for Proviral Integration Site for the Maloney Murine Leukemia Virus. Okay, as a family of them. Okay, PIM 1, 2, and 3, and they are serine threonine kinases, and they're downstream of the JAK-STAT pathway. So for those of you that know about cytokine signaling, they're downstream of the JAK-STAT pathway, and PIM kinases are involved in many processes in the cell. And so, apoptosis, so they can block apoptosis, cell growth, transcription, transformation, drug resistance. And so in my laboratory, we tend to focus a lot on drug resistance as well as apoptosis as well. So again, very important proteins found in all cells, but in cancers they've been shown to be overexpressed. And they were first found in hematological cancers. They were first found in a lot of leukemias and lymphomas, but over time they've been found in many solid tumors, including pancreatic cancer. And this is just some of the substrates that PIMs can phosphorylate. Again, PIMs are kinase, so they phosphorylate to usually activate proteins, although phosphorylation can also turn things off as well. So these are some of the many substrates that you can find. PIM phosphorylating to have impacts on different processes in the cell. Again, as I say, I tend to focus a lot on apoptosis, drug resistance, and cell growth. And so, just real quick, just going to show you some data with the PIM kinases. So we show that these PIMs are expressed in pancreatic cancer. Okay, so this is just showing PIM3 is upregulated in pancreatic cancer, and we also show PIM1 is also upregulated in pancreatic cancer. Studies haven't shown PIM2 being involved, but we've done some preliminary studies to show that it's probably involved on some level, but usually find PIM2 more in hematological cancers. As I said, we first got into this because a paper came out where they did a microarray and showed that PIM may be downstream or may be influenced by KRAS, and so we wanted to follow up on that study. And so here we took some cells, and HPNEs are normal pancreas cells, and HPNE KRAS 12D cells are cells where are transformed by the KRAS mutation. And we did a Western blot, and we see that PIM1 and PIM2 are increased when you have increased activation of RAS. And then we took pancreatic cancer cells where we basically knocked down KRAS, using shRNA, and then looked at the PIM expression. And really, only PIM1 is the only PIM family member we saw where there was a decrease in the decrease in the PIM expression when you decrease RAS, suggesting that PIM1 may be more influenced by KRAS activation than the other PIMs. And we show here that PIMs are involved in growth, and so this is anchorage-independent growth, which has been representative of what could happen when you put cells in mice. And so we show here that when you decrease PIMs, that you also get decreased colony formation as well. And then, of course, again, pharmacologist, so I care about drugs, and so I took a PIM inhibitor, PIM kinase inhibitor, PIM kinase inhibitor. Sorry about that. Okay. PIM kinase inhibitor, SGI-1776. We took that drug and we treated cells with it, either by themselves or in combination. So we did 2 cell lines, Pancs and Miyapacas. Let's just focus on Miyapacas because of lack of time. And so as you can see that, again, this is control. So again, drug concentrations versus cell viability. So untreated, nothing happens. Gemcitabine, which is one of the main chemotherapeutic drugs used to treat pancreatic cancer, not much happens, which unfortunately is what happens in patients. It doesn't really work that well. And then with the PIM inhibitor, we don't really see much that happens, but when we combine it together, we got this synergistic decrease. Okay? Suggesting that, wow, okay, there might be something here, Okay, and so that leads me to the last part of my talk, drug combinations and chemotherapy, So, when it comes to treating pancreatic cancer, there's there's not really much out there that's been shown to be very successful. So again, chemotherapy basically kill cancer cells either by the cells dying or inhibiting growth. And in terms of current drugs that are available, these are the main ones. These are some of the main ones that are used to treat pancreatic cancer. But again, there's no magic bullets here. And again, the majority of folks that get pancreatic cancer, they become resistant to the drugs that they're on. And so the idea is we need to, try to find, other combinations of drugs that hopefully will help patients. And so, or PIM kinase inhibitors, is that a possible idea, possible choice? And so various companies have developed PIM kinase inhibitors. Again, I just showed you SGI 1776. So this made it to clinical trials, but unfortunately it got knocked out due to a potential side effect that occurred. And so this was a second generation inhibitor of this, and then this is another PIM kinase inhibitor from another company. So this was Supergen that made this one. This was Tolera Pharmaceuticals, and this is Inflection Biosciences. And so you got these different, and there's many more. These are just some of the ones that we use in our laboratory. And so they seem to be very effective as single agents in hematological cancer. So in clinical trials, you'll see them in hematological cancers, and they seem to work great. But unfortunately, with solid tumors, they're not as effective. And so in many cases, we're going to have to do combinations to really see something as it relates to these cancers. Okay? And so the idea is, if we combine these PIM inhibitors with chemotherapy, would that make a difference? And so we did some research, did some assays in the laboratory and looked at different pancreatic cancer cell lines and the different inhibitors. The different PIM kinase inhibitors I showed you. Looking at the IC50s here. So these are the IC50s, and as you can see, this one definitely seems to be better in terms of having lower doses needed to have the IC50. And then these are some curves just showing, again, basically, looking at the IC50 and showing who's more potent. And so some of the things we did in the lab, we did this drug screening where we took these approved chemotherapeutics from NCI, these 88 FDA-approved chemotherapeutics, and we combined them with different concentrations of the PIM inhibitor. So chemotherapy alone and chemotherapeutic plus the EC30 of the PIM kinase inhibitor. And, I'm not going to show you a whole bunch, just going to show you one little example. So here we're showing rapamycin is an mTOR inhibitor, okay? And so here, so we got this curve here. And so the blue is the chemotherapeutic, the rapamycin plus the PIM inhibitor, the TP3654. So as you can see, so we got the red curve being the chemotherapeutic alone. But with the PIM inhibitor, the curve gets pushed to the left, showing more potency. So again, just showing that potentially combining the two makes the combination. So again, the idea is potentially the PIM kinase inhibitor is making the cells more sensitive to the chemotherapeutic. And this is just kind of like a cartoon kind of showing, exactly, what we're trying to do. So in this particular case, so we have a PIM inhibitor, and then, you have the rapamycin, that combination potentially works better together than separately in terms of causing, hopefully, cell death. And there's another example of a combination that we did. So we did, we did PIM inhibitor and chemotherapy. Here we're doing, we're doing PIM inhibitor and a tyrosine kinase inhibitor, the ponatinib. And we see the same thing. We see basically when you combine, again, so the dark is ponatinib. It's a BCR-able tyrosine kinase inhibitor. So by themselves, ponatinib alone, nothing really happens. The PIM inhibitor alone, really nothing happens. When you combine the two, you see definitely a decrease. So conclusions. So one levels may be useful as a molecular target marker for determining mutated KRAS activity in pancreatic cancer. As I showed you, PIM1 seems to be mainly modulated by activated KRAS. PIM3 is an important modulator of chemoresistance. So when we inhibit PIM3, we make the cells more sensitive to chemotherapeutics. PIM1 and PIM3 seem to be, although they're very similar in structure, they have overlapping functions, but they also differ in some ways as well. So we need to keep that in mind. And then PIM inhibitors, decrease the cell viability of pancreatic cancer, alone, but seem to even do better when in combination with chemotherapy and other targeted therapies. And then last, I just want to show you, some other stuff we're doing in the lab. So, again, I'm interested in drug resistance. PIM inhibitors are, involved in drug resistance. And so here, a recent paper that came out a few months ago last year, we're using spheroids to basically, to study synergistic effects between different drugs. And so we have here these spheroids that are made of miapockers that are resistant to gemcitabine, and then we treat them with different drugs to see sensitivity or drug resistance. So that's something else we're doing in the lab. And then also we're studying the stroma as well, in terms of trying to find inhibitors for the stroma that is the tissue that blocks the pancreas and keeps drugs from going to the pancreas. So in acknowledgements, again, this is a team effort from folks at my institution, North Carolina Central University, as well as at UNC Chapel Hill, Duke, and other pharmaceutical companies as well. And so thank you for your attention, and we'll have a quick panel for maybe, 5 or 10 minutes to answer any questions you have. Thank you.
Rainer Grüssner. I'm a surgeon by training, and I distinguish between surgical tumors and non-surgical tumors. Surgical tumors are, for example, colorectal tumors, breast tumors, and 5-year survival is anywhere between 60 and 80%. Non-surgical tumors, I must admit, is pancreatic cancer. You showed it nicely, Dr. Baines. Only 8% or 8 patients of 100 at 5 years are alive. Now, the point that I want to make is the following. The reason why we lose these patients is not because of local growth. We lose them because of early dissemination and metastases. So when I take a tumor out and the pathologist tells me all the 20 or 30 lymph nodes that come out with the Whipple procedure are negative, but I send them for PCR, 35%, 1/3 of these tumors already have the metastatic spread in them. So I'm told everything looks great, I send it out, and 1/3 is already diseased. If we did, what we don't do because the insurance companies won't pay for it, if we did bone marrow biopsies before the patient is rolled into the operating room, 1 in 6 already has metastatic disease in the bone marrow. So it's a tumor that is very, very distinct from other tumors. So my question is because I have been following this field for many, many years, and as with so many other tumors, we have focused on the antigens of the tumor cells, try to attack them, create new antibodies, and try to destroy them. But the problem of that tumor cell is not necessarily the antigen that are sitting on the cell. It's the genetic information that makes this tumor metastasize early on. And wouldn't that maybe require, a different approach than what we are doing with most other tumors? I must say I both enjoyed Professor Fearon's presentation and your presentation a lot, but the question really is should we treat this tumor in a different way? Because not every solid organ tumor is like another solid organ tumor. We already know that the hematological tumors are different than solid organ tumors. But don't we have to distinguish between the ones that have shown great outcome after 5 years, like colorectal and breast cancer, and the ones that are doing so poorly, and that is the pancreas, the esophagus, and the lung?
We published a paper this year supporting your observations in Science, where we found in 5 of 5 livers, collaboration with Christine Yockby-Donahue at Sloan Kettering in a rapid autopsy program, livers that had no apparent macrometastatic lesions, we found single disseminated cancer cells in 5 of 5 livers. I think every patient going to surgery has disseminated cancer cells. I think the immune system is probably keeping those disseminated cancer cells from growing, but I think the actual operation and post-operative period where you have to restrict food intake, leads to elevated cortisol levels, and that's immune suppressive. And the dormant metastases can grow out. And in about 10 to 14 days, an immune suppressive microenvironment would be established. And so even though the patient's immunity will be restored when the cortisol levels come back to normal, when patients are being adequately caloric balanced, those metastatic lesions are out of control. And that's why the great majority, 90% of your patients having an apparent successful pancreatectomy have recurrence within 2 years, I think. So we're conducting studies now with the pancreatic cancer surgeons at Johns Hopkins to document the elevated cortisol levels, which have actually been shown in Japan postoperatively, and perhaps approach the problem by hyperalimentation so that the patient doesn't have a normal physiological stimulus to increase their cortisol levels, which you and I would do if we were deprived of food for 2 days. And that's immune suppressive. So I absolutely agree with you. We need to deal with this problem. The second order of things that we're trying to do is, I just want to know whether or not combination immunotherapy will take care of the growing metastatic lesions as well as the primary. And the data I presented was of metastatic lesions. Blocking CXR4 alone increased the immune reaction in liver metastases. But, we don't know till we do the phase 2 trial.
Yeah, and I would just add to my colleague that studies have shown that it's believed that for pancreatic cancer, that window of going from a normal cell to a metastatic cell, that window is very short compared to many other cancers. And so, I would say that in addition to what we're doing, we really need to spend more time trying to focus on cancer prevention. Since we're not able to detect the cancer early enough, I think more effort needs to be put on that topic of trying to find ways to prevent the cancer from even forming, with diet and lifestyles. But I would say that for some of these cancers like pancreatic cancer, that again, as you said, surgery is almost very limited for most pancreatic cancers, and then the treatments that we just talked about, many of them don't work. So I think more efforts need to be put on cancer prevention as much as possible as well. But that's hard too, because again, we still how do you prevent something that we still don't have a way to really detect early on? So still a lot more work that needs to be done. So anybody want to become pancreatic cancer researchers, we need you. Other questions?
I have one, if not. I apologize if I missed this in either of your presentations, but have either of you seen or been able to study if there are differences in the expression either of the PIMS or the CL12 among races, like whether the tumors have any differences in those, and if you've been able to look into that?
I haven't, although I'm interested in it because, again, there may be some differences. PIMS are in all cells, but again, in terms of activation and phosphorylation activity, I haven't looked at it yet because, again, it's hard to. So people are just now really focusing on gaining cells from African Americans and other populations. That's why I'm very happy to be here and very happy to be connected here, because now those studies can be done where you now have comparisons between Caucasian cells as well as African American and Hispanic and other ethnic groups. So great question. So hopefully in the future there'll be something that'll be done.
We've not made a specific attempt to see that, but since I think it's universal among mammalian epithelial cells that are under stress, because we find it in mice and even normal colon epithelial cells in the mouse.
My question is to Dr. Fearon's work, right over here. Hi. I was interested in your data showing that pancreatic cancer cells with high microsatellite instability seem to have a little bit more of T-cell infiltration. So the idea that microsatellite instability leads to genomic instability or is an indicator of genomic instability, making those cancer cells a little bit more immunogenic, would that be sort of a key here, that the pancreatic cancer cells are just not as immunogenic and thus not triggering T-cell killing as avidly as some other cancer that would otherwise be, checked by the T-cell surveillance?
So that's a critical issue. So microsatellite unstable pancreatic cancer and also colorectal cancer, the 15% of colorectal cancer patients that are MSI high, they do respond to anti-PD-1. So those infiltrating T cells are relevant. There are attempts of making cancer cells more immunogenic by histone deacetylase inhibitors, things that make cells transcribe more genes. Those would be germline encoded genes for which we might have partial tolerance, though, and lower affinity. The microsatellite instability causes mutations that involve frameshift mutations, so the whole new peptide is immunogenic, it's not a point mutation. So that's the most immunogenic kind of mutation you have, and patients that have it can occasionally respond to anti-PD-1. But I don't think making a cancer cell more immunogenic is a practical approach. It's actually absolutely surprising that we are not we're not increasing the antigens expressed in these patients already have ongoing immune responses to pancreatic cancer. We just can't appreciate them because the T cells are excluded from the cancer lesions. So I have hope that if we fully remove all inhibitory pathways suppressing the intratumor immunity, we will have a significant proportion of patients responding to immunotherapy that have not previously responded. I hope.
Now, I just have one quick question. Do those pancreatic cancers that have BRCA mutations, are they more immunogenic?
So the BRCA mutations may also cause changes in a cancer cell that might lead to a type 1 interferon response. And type 1 interferon is very pro-immunogenic. It promotes an immune reaction by inducing the chemokines that attract T cells and so forth. So that might be a mechanism by which BRCA mutations increase immunogenicity. We didn't screen for our pancreatic cancer patients for BRCA mutations or the colorectal cancer patients, just MSI. I don't think a careful study has been done of that, of whether there are racial differences or whether there are differences in the immune system that are race-based. There are obviously mutations that affect the immune system that they will manifest as impaired host defense long before the patient probably gets cancer. But I'm not aware of that. But I'm not aware of studies. So it's an open question. Can I say one other thing? Race-based, economic-based access to health care. I lived in the UK for 21 years, and we have a National Health Service. I came back to the United States 4 years ago. I cannot understand why the United States does not adopt a single-payer system, since the cost per capita in countries that have single-payer systems is less and healthcare is better.
What is the success rate so far with genetically modified T cells being reintroduced into the body? What is the success rate with genetically modified T cells being introduced into the body?
So I think your question is about CAR T cells? Yes. Right. So chimeric antigen receptor T cells are T cells that have been engineered in vitro to have a souped up T cell receptor that recognizes membrane proteins on target cells and is effective in B cell lymphomas, I hope myelomas, but has not been effective in solid tumors yet, in part because solid tumors have this capacity to exclude T cells, whether or not whether or not they're endogenous or you administer them by adoptive transfer.